Well, I'll start with one that's self-imposed. What do you do when you come out of fellowship and you go into practice? And some of that was touched on earlier yesterday when you're thinking about the environment in which you want to practice, the type of practice you wish, whether it be a health system-based practice or whether it be a university, academic, or a private practice, and what kind of community you want to live in, because those are real important non-medical decisions, but they're really important. And then from that, the basics of practice have never changed. It's a relationship-based business. You have relationships with your colleagues, and you want to go out and press the flesh, as the politicians like to say. Now, they do it kissing babies, but you do it shaking hands of colleagues, introducing yourself and identifying what you can do for them. And you do that continually until you're integrated into the community. So you want to set time aside for that.
Woohoo! Question.
All right.
Yeah.
It worked.
I think it's more so just, as us looking down the barrel of a new practice and a new career. What are some kind of pearls or tips and tricks in terms of having a good, efficient practice where you see people in clinic, you identify them as a potential for dorsal column or for DRG, and then you get them through the whole process without losing them along the way? What are some tips for efficiency, I guess?
Yeah, that's a great question. I don't know if this thing's Can you guys hear me okay? Yeah. So, number one, I think most of you are in this transition, fellowship, and then you'll go out and into practice. And I think when I was at UCSF and I had fellows, one of the misconceptions was that when I graduate from fellowship, I'm done learning to some degree. Because you've done all this training, right? Med school, residency, fellowship, and you think I did it. Now I get to go make my beans. Awesome. And the truth is, you're going to continue to learn forever. So just instill that now. And all the stuff you're seeing me do today or yesterday, I didn't do it all in fellowship, guys. The only thing I did then was spinal cord stimulation and pumps. So it just goes to show that whatever you guys learn in your fellowship, it's not the end. You have to continuously learn. Now, as far as efficiency in your practice, this is a great question because I love to be super efficient. I'm a freak about time. I love Japanese, German train stations, all that kind of stuff. So it's all about algorithms. How do you set up the complexities of patient management when it comes to pain in a way that gets you through that process quickly? So a good example is spinal cord stimulation. Obviously, you're going to spend a lot of time going through patient selection, contraindications, and all of those things. And as soon as you have a candidate, you're going to think about a pain psychology evaluation, because that's required by most payers in Northern California, depending on your local, LCD and all that stuff. They have to go through a trial. You have to document the results of the trial. Then you do the PERM, 2-week post-op follow-up, and then a 6-week post-op for reprogramming. So what we do in our practice is we lay out that entire map. I've written a 21-page document for patients regarding all of the risks and benefits regarding spinal cord stimulation. They have questions like, what do I do about sex? What do I do when I go through the airport? What do I do when I have an MRI? Your goal is to reduce the amount of time you're talking to patients, but yet inform them, right? So early on, definitely spend the time. Don't go too fast. These are things you learn over time. So by year 2, year 3, I was thinking, gee, I need to create something that expedites this process, but yet doesn't shirk my responsibility to inform them of the risks of the therapies we're doing. So lay it all out. This has been one of the biggest game changers in spinal cord stimulation, so that when my MA comes in and gives them that packet, they know the exact roadmap to get through implant and programming, et cetera. You're absolutely right. If patients fall off or they're not aware or understand that, you're going to lose your efficiency or you're going to lose them benefiting from the therapy. So it's really important to lay that all out. And so you can take that same sort of complex algorithm with spinal cord stimulation and you can apply that to SI fusion to lumbar indirect decompression. And those are generally easier algorithms in some ways, but more complicated as far as patient selection. So your algorithms for everything you're doing are always shifting and changing depending on the evidence, depending on reimbursement, depending on your own personal outcomes. Because look, if the evidence looks really good and you do something on your own, you're not getting the same outcomes, which happens. You know, there's a therapy out there, I won't name the name of it, but I don't have the same outcomes as what their RCT showed. I stopped doing it. And that's why I go back to tracking your outcomes. That's why, you know, the registry data that Niels talks about is so important, so that you're always iterating upon your algorithm to, again, do what's best for your patients.
Just to echo on that a little bit. So one of the things that I found most helpful, both in terms of proficiency and efficiency, is relying on your colleagues. So, you know, unless you're going into a solo practice, you know, Godspeed. That's very, very brave. And some people do a great job of that. But for the rest of us, you'll be joining a partnership or some sort of group. You know, they've already been there a little bit before you have, and they've had some pearls of wisdom that they could give you. Pick their brain. You know, there's always, it's kind of like, you know, when you do a PowerPoint slide, there's always something that you learn from every time you do do the teaching and then learning the teaching. So ask your colleagues, you know, ask them around. Chances are, if you have a question about some sort of authorization or some sort of code, they've already kind of been in that situation, you know, however many years ago. Unless it's changed, they'll probably have a lot shorter answer for you rather than having you do all the searching. And techniques. You know, if you have certain things you're having trouble with, identifying fluoro images and whatnot, you know, just scrub in with one of your colleagues and just see how they do it. You know, I did that a lot the first year I was here. Fortunately, I was in the presence of a lot of people who do a lot of neuromodulation and vertebral augmentation, so I had a chance to do that. And once you know the anatomy, you know, and you're obviously going to be ready, the more learning you do, obviously you're going to just kind of catapult yourself into a better spot. As far as efficiency goes, I would say just invest the time up front. So when you first get started and when your clinic is kind of slow and when you don't see a lot of patients, you're only seeing about 5 a day or whatever, don't go home and don't go to happy hour. You know, just go to the front desk, talk to the PSC or the person who does the registration. Talk to your scheduler. Talk to the rep. You know, just kind of create a nice little workflow for yourself. So, you know, like for neuromodulation and things like that, doing the trials or the implant is arguably the easiest thing to do, right? It's the stuff the administrative stuff that comes before it, getting the psyche eval, you know, getting people in at the timely manner, getting the OR schedule, you know, all that stuff will be a lot more streamlined if the people who's helping you know exactly what to do.
So I think that SCS is fairly unique in how difficult it is to sort of wrangle in all the pieces from education to all the steps in authorization to the point where you would be in the operating room doing a perm. Education is a big piece of that, and the way that I've approached that is I don't want to spend 20 minutes with each patient talking about every permutation of the details that they could encounter during their permanent or trial period. So I educate my MA and the nurse and the person who's going to call them to schedule the trial or the surgery. So I have educate my staff so then they can be the educators to my patient, and then they all have consistent information that can be reinforced if the patient calls back with a question or a clarification. And then the device companies are kind of caught on to how hard this is for us, and so they are offering a lot more resources, from authorization support or portals where they can give you some sort of a tracking method, or your clinic authorization staff a tracking method to know where the patient is in the process. And they also have really caught on to helping us with the education. So every one of the device manufacturers has their own sort of flavor of website or electronic resource. And there's, you know, kind of you'll have to look and see which of those you are most comfortable with. But there are a lot of resources out there so that you don't have to be the one kind of sitting there with every individual patient repeating yourself. Yeah.
I'll add to this from a surgeon's perspective, because our practices are a little bit different, but there are a lot of analogies. So what I do when I started my practice is I identified the 10 things that I do frequently, I do well, and would make up the majority of my practice. And for each of those 10 things, I wrote a patient letter. And the letter describes the symptom complex of the individuals coming in, so it serves as an education piece that the patient will read and go, yeah, right, that's me. And then I wrote out the process of care in layman's terms, not physician's terms, and then the expected goals. And I listed the adverse events that happen along the way, but I put them in sentence structure that wasn't threatening, but it was informative, and it serves as an education tool. And the two things that everybody's been talking about here is process of efficiency and education. And then I give that to the patient. I give them 2 copies. One they take home, and one they sign, and I put in their medical record. And what it does is it reminds me that I gave them their letter. That letter has embedded in it the buzzwords that you would search on the internet. So those words are like links for them to click on that, and you can watch a movie of your operation, or you can see an internet education piece. And so when they come back to see me for treatment, they understand the language, they understand their condition, they understand that they're part of a large group of people who suffer similarly, and these are the things that they can expect. The unexpected benefit of it is it resonates outside your practice. So a decade or 2 later, someone will come up to you and they'll be part of the jurisprudence aspect of our society, and they'll comment that that letter was really impactful in their decision not to take the case for patients who didn't have optimum outcomes, because the informed consent letter fully explained in layman's terms. So it can have impacts not only from an education and patient and a efficiency perspective, but it has a wider impact in the community in general.
And these are all great points. One thing I have to add to that is how important is the right staff, whether it be your front desk person, to your MA, to your nurse. Having the right staff is extremely important in helping to, as we talked about, educating the patients. But if you have control of hiring, helping to hire the staff is quite important in making your practice quite efficient or not. Over the years of having staff turnover, sometimes you can't control these things. But if you have a say in the staff that you bring on, it helps to provide quite a bit of efficiencies, because you're able to train them more proficiently, and they're able to educate patients on your behalf. But that's the main advice I'd have. Other question?
I have a question about finding your first job and choosing your first practice. And I see, differences between private practice, small solo practice with a lot of flexibility of what you can choose to try, new procedures, and hospital-based, a lot more rigid system, and then trying to create that practice that you want. And just wanting advice on how do you either, should you just go for that practice where you already see those things that you want to do and it's already there? Or is there room for creating your practice that you want in a hospital-based organization? What are the pros and cons of that decision?
Yeah, I'll definitely take that one. Since I've been in academics for a while, I've been in private practice, and we've definitely shopped out to large health enterprises. So I think the first piece of advice I would give is don't expect your first job to be a forever job. And I think, in medicine, quite frankly, historically, that has been the case. You have people who have 30, 40-year careers from the job they had out of residency or fellowship. And as you guys know, you guys have tech friends. They change jobs every 2 to 3 years, right? They have 17 career, you look at the resume, like, good Lord, can you stick with anything? And honestly, I do think that is happening more in our area. And a lot of that has to do with healthcare forces regarding conglomeration, and the struggles of private practice, the reductions in reimbursement, overhead, malpractice. All of these issues are what are generally shifting physicians, especially in your generation, towards more of the organizational health enterprise type setting because it's safer. The downside to that, as you already mentioned to some degree, is you don't have as much control or free will to do the things you want to do because, as you said, that it's fairly prescribed what you can do. And you can't hire and fire who you want. You can't create the practice exactly how you want. But again, you're getting good benefits, the money is generally good, so that's all safe and good. It does thwart innovation, though. So a lot of the things we've talked about, you can't find in major systems because they're very reticent to approve that from a financial standpoint, or they're just not aware of the evidence supporting its use. It will take years for them to get to that point. For me personally, when I was in academics, I actually thought I'd be in academics for the rest of my life. I thought I'd be at UCSF until I retired. The issue I came across, frankly, was I felt there were too many barriers to do the things I wanted to do. Like I had a lot of vision for pain, for regional anesthesia, for acute pain, et cetera. And I just felt like there were too many obstacles. So when this orthopedic practice came and approached me, I just went in with open eyes and I was like, this seems amazing. So I made the leap. And that transition was scary because I didn't know what I was getting into. Quite frankly, I took a hit on money. I took a hit on benefits because UCSF was great. But I had full control. I could hire and fire who I wanted. I could set my hours. I didn't take any call. It was weekdays only. It allowed me to do anything else I wanted to do, like consulting with all those like 20 companies you saw, and lots of other things. So from a personal life balance, as Neil was saying, it's really important to know what you want to do in life. That transition was very good for me, even though I make less money. So I think right now you kind of want to figure out like what kind of personality you have, what your life setup is like, partners, children, everything, family, and figure out what is the right thing. If you have the ability to take more risk, I would always tell people go private practice because I think that's good for medicine. I think that's good for, innovation, creativity, and your own satisfaction. There are going to be major hardships, as I mentioned, overhead costs, et cetera. COVID, I basically went without a paycheck for 3 months. It was hard. But it's just something you're going to have to balance. And like I said, if it doesn't work out in the first few years, switch. And you can always switch again. But just be open to all of those opportunities because they're all out there.
So I've worked in this field for about a little more than a decade. And the first half was in one hospital system and the second was another hospital system. And I would say that the reasons that I've selected that is because I really want to take care of patients and I don't want to manage a business. And I like going into work and not having to worry about if there's printer paper. And I like that if my MA decides to leave, then I don't have to worry about advertising and locating and interviewing and all of this stuff. I don't have to worry about the medical assistants, nursing benefits, none of it. I also really appreciate that I'm sort of gift wrapped a lot of the billing things. I mean, when there are changes in reimbursement, when, Blue Cross no longer covers intra-articular facet injections and only MBBs. I do not have to do that. The billing people or my clinic administrator comes to me and gives me every 6 months an updated, billing coding issue sheet. So then I can focus on patient care. And there are limits, right? And Rama's right. I mean, I don't find that it is actually the healthcare systems that limit my abilities, like what I can do, what procedures or whatever. It's usually people, and it's usually surgeons, right, who have very often leadership roles in our hospitals. And they have really strong voices, orthopedic surgeons and neurosurgeons, because they bring in the money, right? And so hospital administration listens to what they have to say very carefully. So I find that, when I want to do mild, or when I'm not doing mild, but I would love to, and I'm having those struggles right now. When I wanted to do Intercept, or when I wanted to do Vertiflex, which I'm doing, it was not always fun to have to, sit down with people that had strong opinions against those technologies. But I really found that if I had integrity in always bringing the conversation back to safe, right? We learned about this yesterday from Peter and Nora, talking about safety. What were the things? In appropriateness, effectiveness, and finance, right? Then it was pretty hard for them to argue their way around it, and that's where I have success. And I know I'll do the same with mild. It's a process, and it probably is a healthy check and balance, in my opinion, that I have to sit in front of other people that may have an opposing opinion and prove to them on those tenets that what I want to do is the right thing.
I'd say there's probably very difficult to find the perfect job, and that's not just dedicated to medicine. I don't care what field you're in. Finding that perfect job is very difficult. But it's about job satisfaction. So if you actually cast a net, and there's a lot of variables like family, personal aspirations, autonomy, just skill set, whatever you want to get involved with, even maybe management, right? It's just about, of all those factors, like multiple factors, how much of that do you get to cast in your net? And if your top 3 or top 5 or whatever gets casted in that net, then your job satisfaction will go up. But not just that, that's just prioritizing, but I would encourage you guys to kind of put a temporal timeline on it. So for me, it's important to just kind of the way I think is, it's important to set a short-term and a long-term goal. I usually tell my patients this when I manage opiates, hey, look, we're going to be on it for this amount of short-term, or we kind of plan out the map. And that kind of applies to your career or your first job too. So I think they say like 50% of residents or fellows who graduate with their first job, they relocate or switch jobs within the first year or something like that. So the statistics are not that great, but you could, of course, increase the odds of that just by kind of finding out, hey, what do I want to do for the next 3 years? Or, hey, what do I want to do for the next 5 years? And if you're not really happy there and your job satisfaction's high or low, then obviously you want to switch and create something for better. But, in the first 3 years, you're like, hey, out of the 6 things I wanted to accomplish, I actually got 3 or 4 done. That's not a bad, that's not a bad gig. And you might want to extend your contract a year or so more. So I would say, you don't have to put too much on your plate the very first job that you take. Just give yourself a little timeline, though, kind of like a mini checkpoint and a finish line. And obviously, that sort of depends on your significant other and your family and your social situations, too. But I would say that would serve as a very good progress report as you go forward.
So there's so many new technologies coming out every year, it seems like. I just want to hear your perspective and philosophy on from when they're introduced to the market to evaluating them, evaluating the data, and bringing them actually to the bedside to your patients. Can you talk me through your sort of timeline and approach?
I'm going to speculate, and please, everybody up here, how many of the folks sitting up here are still doing procedures they were taught to do in their fellowship? How many of the folks up here are doing procedures that were not even conceptualized in their fellowship? So you're going to constantly embrace the innovation that Ramo mentioned earlier, and you're going to take the principles that you were taught, and you'll apply them to the new technology, because that'll keep you safe. And then the new technology will become the principled skill set that you have as you add the next layer. That's the beauty of medicine. It is a constant growth curve.
Yeah, I think the most important thing is certainly to be aware of all the new technologies that are coming out. You don't want to be somebody who doesn't progress or evolve. On the flip side, you don't want to be somebody who just grabs on every new thing and starts doing it in your patients. So this question is super important because this is what I'm confronted with all the time. And in fact, I know Neil and others and Doug get involved with these therapies before anyone really knows about them. And so we help them create the roadmap to get it to the marketplace. And really, it's really simple. We need good level 1 data, right? So I need a good RCT in the right patient population. You got to know what the reimbursement is like. And you got to make sure there are enough patients and that the therapy is safe. And if all of those things basically check out, then we can proceed. Now, there are therapies right now in the market that are Me Too products, that they themselves don't have the level 1 evidence, but the Me Too product they're mimicking does. So you have to sort of understand, like, where does this fit? Maybe this is a little bit different, but, it's sort of like that therapy which has this evidence. So there are little caveats to things that I'm doing that don't have the level 1, but you would find a corollary therapy that does. When there's a therapy that really doesn't have any evidence, I'm really, really reluctant. So even some of the therapies that are out there here and outside of here, I'm involved with, but I'm not doing because I'm still waiting for that evidence. I'm still waiting to understand what that patient population looks like. So I think the most important thing you can do is, again, be open to all of these things and just kind of feel out and understand from all of these aspects when it's right to do it. Because he's right. I mean, every 3 months there's a new therapy. I mean, there are already 10 things that I know Doug and I are working on that no one knows about yet because they want help in trying to get it to the market. And you'll probably hear about them in 5 years or not. Maybe they won't make it, So there are a lot of interesting ideas out there, which is really fun. But yeah, I hope that.
Yeah, you need to kind of be thoughtful about the balance between being excited about these innovations and then also really weighing that against where the evidence is and what the standard, like what your community philosophy is. Because you want to protect the specialty's integrity in depending on the foundation of good evidence, right? Not just kind of excitement and an idea, but if you're going to do something to a patient or your mom or anybody, right, you would expect that it's not just an excitement for an idea, but it's really founded on medical evidence. And I would just say that it's maybe not the opinion of some of our other panelists, but I think that it's really important to preserve your integrity as a new provider coming out of practice, that you're not a cowboy in everything you do. Be exceptional at the things that you do, and then take measured steps forward, embracing new technologies and new innovations as the evidence leads you. Am I the conservative one up here?
No, I totally agree. Yeah. And if you kind of want to gather as much information as you can or want, those national conferences, a lot of other people are kind of doing the work for you. So if you really don't have access to all the services or the equipment or the literature, those national conferences, there's always a presenter who has sort of done the grunt work for you. And obviously you don't want just a singular opinion, but, just giving yourself exposure to that is always a good thing. I think, when you get busy as an attending and you just focus on your work alone, it gets a little easy to be a little bit lackadaisical about national conferences and committee meetings and things like that. But it's a really good resource. I mean, you're just going there really to just listen to what they have to say. You don't necessarily have to agree or disagree, as long as you know what PRP injections involve. You may not even have to institute it in your practice, but what does it involve? What's the literature on peripheral joints versus spinal injections? That's already so much information that you could benefit for yourself. Again, you could wait 5-10 years until you do it for your patients, and I probably would, but at least you're equipped. Yeah.
Can I add something else? Or Glenn, do you have more to add?
Go ahead.
Okay. So just to add on to this question, can you guys hear me okay? Okay. So one of the most important things that you can do, if you can start this right now, is take a new therapy through your healthcare system. Start doing it now, even as a fellow. If there's a therapy out there that you learn this weekend that you guys are not having access to, figure out how it gets approved. Because this is this was kind of what gave me strength, is that I like figuring out things. I like problems. I like challenges. So when I was at UCSF, the big, giant UCSF, I started bringing in the newer spinal cord stimulation therapies. And before I know it, the chief of the Health Technology Assessment Committee asked me to be on the committee. So now I was assessing all the technologies for cardiology or orthopedics and everything else, along with 10 other doctors. And in that process, I learned about the entire structure, hierarchy of how things get through. And then when I went private, this community hospital I'm now in Marin County, they didn't have any of this stuff. So what did I do? I took 7 new products and I marched them right through PNT, VAT committee, medical director, the CMO, everybody. And now they're all, this is great. If you guys don't learn that now, you're never gonna be able to do these things, right? Because you're gonna learn all this stuff and then you go back to your hospital and you can't do it. What's the point? So not only go through this process, but in doing so, you're giving yourself that seniority in your hospital system or enterprise, right? One of the first things you can do, we talked about building relationships, going on your community, the ecosystem, go meet the CMO of your hospital. Go meet the medical director of your ASC. Like, you need to be friends with them. As Jen said, the orthopedic surgeons, the neurosurgeons, they're already there. So they have the ear of all those people. And frankly, pain management has always been kind of down here. But you need to elevate yourself to get in their ear and talk about what you can do. I don't think we value ourselves enough. When you actually look at the revenue that we do generate with a lot of these things, it's right up there. So give yourself some credit if you are doing it to say, like, if it's about money, I can bring money. If it's about doing the right thing, I can do the right thing. Whatever, angle you have to take politically, do that, because that's how you make it work. I couldn't do any of this stuff if I hadn't taken it all the way through. There's a lot of hard work that goes behind it. So just learning it isn't enough. You got to be able to take down those obstacles so that you can provide it for your patients.
I'm going to give an analogous experience. When I came out of fellowship and built private practice, then group practice, and then merged it into the large orthopedic multi-specialty group that's out here, I participated in the Quality Assurance Committee, and I participated in building and developing the ambulatory surgery center. In the state of Washington, you have to go through processes called Certificate of Need, and growing and developing that. Bringing surgical procedures from inpatient to ambulatory is what we are now focused in, but we've been doing this for decades. It's your practice, and you can guide it. And your motivation, your skill set, your insight are critical to the relationships that Ramo was talking about, because those relationships end up making your practice environment. And you will end up doing wonderful things in environments where you love to practice, where the thing that all of your patients comment on is I know I'm in your office when I hear laughter. I know I'm in your surgery center when I hear the sound of laughter, because it's such a wonderful environment. And you have the opportunity to do that and build it, but you have to get in and do the lifting yourself.
Excellent. Well, I think one quick question.
Thank you guys for taking the time to put this course together on behalf of all the fellows. My question is if each of you could share either a story or some insight regarding how you secured your best, highest quality referral source.
Sure. Let me start off. We worked with Don and talked with, I had a lecture with Peter Nor yesterday. I can't say enough how important it is when you're getting into practice, not only reaching out to the family practice, internal medicine practices out there, or even the oncology and endocrinology type of practices out there, whether it be for vertebral augmentation, for osteoporosis, and what have you. But really get yourself out there and get to know the surgeons in your clinics, at the hospitals. Reach out, and because you're gonna need a backup. When things go wrong, you're gonna need a backup, and develop those relations very early. because there's going to be need that as you practice, go on and on. You want to make sure that you're keeping yourself and your patient safe. So that's my best advice.
For me, I think it's two-part. One is, definitely get yourself out there. Speak to the medical director. So each referring practice, whether it be primary care, surgical, whatever, they'll usually have someone who sort of coordinates all that stuff. So I would say if you could certainly meet each and every one individual, and I think that would be great. But just to start off, if you just want to kind of talk to kind of the director or the medical director, just get yourself out to shake his or her hand. Say, hey, look, I'm new in town. This is me. This is my business card. Here's a little fruit basket from Costco. And I'll be doing this. This is what I would like to do for you guys, and and have a nice mutual relationship. And what really sustains that is the second part, which is don't just get the referral and just go by your day. It's the little things that count. So like the patients, I guarantee will go back to the referring physician and say like, I had a really good experience. Dr. So-and-so did a great job for me. Thank you for referring that. Referring me over there. That will lead to 2 referrals, lead to 4 referrals, lead to 16 referrals, as opposed to, if you, just don't take care of the little things, like patient satisfaction and things like that, or quality of care, then that person might go back and say like, that experience was okay. And then that referring physician might not necessarily, continue that or sustain that. So it's not just getting your face out there, which is very important, just kind of get you through the door, but also you want to maintain that relationship, and that way it'll just kind of exponentially grow.
So I work for hospital systems. They were there long before I put my foot through the front doors, and everybody knows one another when you're new to a hospital system. So certainly I tried to meet as many people as I can, but I also recognize that there's existing relationships before I got there. So I found that actually going to the emergency department, nobody markets at the emergency department. Are you kidding me? Like nobody goes there. And that has been really helpful for me,
especially
because there's so many hot radix that go there, so many disc bulges, there's vertebral compression fractures, there's a ton of pain needs that go to the emergency department. And those doctors have my number and my medical assistant's number with a guarantee that I'll get them in within 48 hours.
So that's a classic example of relationship. You want to have relationships with your patients, you want to have relationships with your colleagues, you want to have relationships with your community, and you want to sustain those relationships. The ED is, they are swamped. And just the visit to say you're there to help and how you can help, that resonates, but relationships.
So I'll say that to answer your question in a really long-winded way, which I've been doing the whole time here, I think it's really important to know the incentives of everybody around you. And so when I was in academics, those incentives are very different than in private practice. So what I was able to do when I was at UCSF was get people interested in referrals if it was based on the science, based on research, based on a QA project. And that's how I got a lot of surgeons on board for a lot of things, whether in acute and interventional pain management. And when I went to private practice, it's totally different. They don't care about the evidence and doing research, right? What the referring doctors care about is reducing complaints and saving time. So when we talk about how we create those relationships, historically what I was doing, dinners, lunches, emails, letters, none of that worked. None of that was a waste of time. Waste of money, waste of time. What works is when a patient has a success, you tell that patient to go back to that primary or the referring doc, and that's your moment. That's your door that opens up when you can go in and say, hey, we had this mutual patient, they had the Vertiflex, they did it really well, saved them from a LAMI plus or minus a fusion, whatever, and can we talk about this? That's how I think you get the most bang for your buck, because now that physician knows that, hey, you did something good, and now they're willing to listen to you when you want to talk about that and whatever else you may want to do. So, my biggest referral, I was thinking about all the different sources. My weirdest and biggest one is somebody who lives 75 miles away from me. And what happened was a patient, in wine country, came down and had a Vertiflex and did phenomenally well. And he went back to that primary and he's like, you got to send all the patients down to this guy. He's doing it. And there's no Vertiflex in that county. So this primary care called me up. We had a conversation and we created an efficient, streamlined pathway because those patients are coming from 75 miles away, at least. And so, especially after COVID with telemedicine, that made it much easier. So I was like signing up patients for surgery via telemedicine. They were coming down. We built our surgery center, great experience, and it's just built upon that. So always take advantage of those moments of success. It's like this accelerator. It's like, boom, hit it, right? But if you just cold call, I'm just telling you from experience, it just doesn't work. We're too busy. They're like, yeah, I got bagels from this person, and it's all the same. But if their patient did well, jump on it.
Excellent. Well, we're going to be switching over to the fish bowl there. And